My name's Brian Lally. I'm from the University of Pennsylvania. And I got the privilege this year of heading up the lung group for the steering committee. And I just wanted to thank ACRO for inviting me and my fellow presenters today. We assembled a panel that includes the two co-PIs of the VALOR study, Dr. Drew Maganaki and Dr. Karis Tomer. I'll be talking about, sorry, I screwed that up, I'm sorry. Dr. Tomer Karis, I need to calm down. And then I'll talk a little bit about the white paper for SBRT that recently came out. And we were supposed to have Dr. Salma Jabbour talk about immunotherapy for lung cancer. She had some problems with travel, so instead we're going to have Dr. Finkelstein filling in. But to start it off, we're going to have Dr. Drew Maganaki from the Richmond VA telling us a little bit about radiation therapy for operable stage 1 lung cancer.
Good morning, everybody. I'm here to talk about something that I'm very passionate about, and I think a lot of you guys in the audience are as well, which is a treatment of operable stage 1 lung cancers. I've intentionally used large fonts here to distinguish. We're not talking about the patients you see normally on a routine basis. I get a lot of people who come up to me and say, oh, yeah, I do these all the time. No, I'm talking about a patient with a 10-year life expectancy. A lot of you may already know the VA has dedicated $25 million to what we think will be the final and successful randomization of operable patients between two treatments, a time-honored thoracic surgery, lung cancer surgery, and radiation. And we chose the endpoint that matters, that is survival beyond a time length of 5 years. Even if we did it at 2 and 3 years, I think the debates would not end. Furthermore, we have to measure quality of life metrics to see if there really is a quality of life advantage to SBRT over surgery. Data that I've seen from prospective cohorts, non-randomized, suggests it might not be measurable. It's something we believe, but it might not be measurable. Next, or finally, I will just point out about the study design. The VA was uninterested in a non-inferiority study. Why would you use taxpayer dollars to show a treatment that was just as good? Just use a treatment that's working. So the study actually is a superiority trial, giving the opportunity for surgery to win or lose. SBRT might come out as the superior treatment. The details are on clinicaltrials.gov if you want to read more about it. This is the executive study team. I'm very grateful to have a wonderful colleague, Dr. Tomer Karis, who is a thoracic surgeon. And we've put basically probably the two strongest heavy hitters in our field on the panel. David Harpole, who's been the PI of multiple CA-LGB trials, is vice chair of thoracic surgery at Duke and leads the thoracic surgery program at the Durham VA. And of course, everyone here knows Bob Timmerman. We have a thoracic surgeon at Baylor and the Houston VA who chairs a surgical advisory committee to make sure that all voices are heard. And this has led to wonderful equipoise. We have exit survey data from our first 30 patients who've been recruited to their trial. Only one noticed a lack of equipoise. All the patients said that the VA clinicians, surgeons, and radiation oncologists have balanced views about these two treatments. And then the bottom right, I put Dominic Rita's name. He's the director of the coordinating center for one of the 5 VA research offices in the VA. This gentleman is a commander who has led us through some really rough waters to get this approved. It's the same center that did the VA larynx trial 30 years ago. And he has 18 New England Journal JAMA publications under his belt and understands how to design trials that compare A versus B, whatever they may be. This is where it all started. I joined the VA in 2011, but in 2012 decided to dream big or just go home. We assembled the panel. Robert Cameron was the former thoracic surgery chief at UCLA. He's a mesothelioma surgeon. There's Tomer and myself, and look at Bob. I guess he wasn't so optimistic. It took several years, but we finally got funded. And I just want to kind of provide some thought-provoking comments for the audience here. How did we get here to think that radiation might be just as good as surgery? Here are the randomized trials that are all being closed. Only 4% of the patients that were supposed to be randomized. We know about the pooled analysis. I won't go into that here. I don't think the data are trustworthy. But I just want to point out a lot of effort has been put into this. And Ben Slotman is in the room and was involved with the Roselle trial. I truly believe that one of the major reasons these trials failed is because our pulmonologists and primary care physicians didn't know what SBRT was back in 2008. It was too early. Times have changed. Some of us are giving lectures at American Thoracic Society. We talk to our pulmonologists. They now know, and if you think about it, they manage the nodule clinics. They are actually the gatekeepers for referring patients to us or surgery, or at least getting to a state of equipoise to agree to be randomized on a clinical trial. But how did we really get to this point? Why did it take so long? Timmerman went to Stockholm in the mid-90s, where they had initially, the Karolinska Institute had first delivered SBRT to a moving lung tumor. And here we are 20 years later, on the heels of 0236 trial and other studies, and still we don't know the answer. I'd like to go all the way back to the very beginning, which is Halsted had a major contribution on the way that we treat cancer in this country and around the world. Radical surgeries was the mainstay. Radiation had just been discovered in the 1890s and was still very immature. A lot of our machines were electrocuting the physicians. Anesthesia had been around since the Civil War, and by the 1870s through the 1890s and beyond, the radical mastectomy led to a lot of things. But over time, we have successfully shown that you don't always have to do upfront surgery. You can do upfront something else, reserving surgery maybe if it doesn't work. However, there are two major malignancies which we still don't really know, and I emphasize the Whipple because there has been discussions about an SBRT versus Whipple study. You'd only have to show a 20% survival at 5 years. In the era of the Halstedian radical surgeons emerged Evarts Graham. If you've read Emperor of All Maladies, there's an entire chapter dedicated to it. If you haven't, all of us as oncologists really should read that book. It's the best book I've ever read about being a cancer physician. And from this group came this thoracic surgeon at Washington University who was able to successfully remove a lung tumor, and the patient didn't die. Here is his patient who lived 30 years later. And in 1933, before antibiotics were available, look at what he accomplished. Operative time, less than 2 hours, only 1 transfusion, no antibiotics, of course, T2N1. There was some controversy about the pathology. They went back and looked at it again, and he was node positive. But there were some radium seeds that had been sown at the stump, and the patient lived 30 years. This led to multiple publications that are very provocative in JAMA in the late 30s and the early 40s, basically declaring, do not mess with the patient with lung cancer. They must be sent to a surgeon, and there are no exceptions allowed. Meanwhile, the next 19 patients had all died with a 100% mortality rate. This set the standard, and from there was kind of, I had a former chairman of the Society of Surgical Oncologists, Walter Lawrence, tell me, Drew, you gotta watch out for these surgeons. They can be bullies. Then, in the 50s and 60s, a medical historian in the UK, Carsten Timmermans, wrote about how, we had started to see path CRs with 40 and 50 gray, yet research funding was blocked. And we were basically left not to advance, what the beam can do. And so, you can see comments such as inoperable patients are hopeless, no reason to fund anything. If they can't cut it out, just leave it alone. Radiation is worse than useless. And this is something we still hear today. We should just focus on smoking, cessation. And nonetheless, fortunately, a randomized trial was actually achieved in the UK. Magic number 58. 58 is the same number of patients that were randomized in the pooled analysis report several years ago by Joe Chang and colleagues. And in that study back in the 60s, you see surgery wins. This is your level 1 data, and you and I think, what are you talking about? I don't even heard about this study. If you talk to prominent elderly statesmen in the field of thoracic surgery, they'll tell you this study was highly influential in the 70s, 80s, and 90s in thoracic surgery education. What techniques were used? Well, first of all, the staging was all wrong. The CT scanner wasn't even pioneered for another decade. Furthermore, radiation was APPA 45 gray, a palliative dose. These data really, they're just of historical content. If we had our own Smithsonian Institute, a copy probably would be on the wall. So, here we are today, in the interest of time, what is the evidence that's supporting us to have equipoise? You may be familiar with this MD Anderson data. Very, very high p-value, almost 1, looking at surgery versus SBRT. I worry about the 3-year event horizon on this graph and possible selection of patients that were fit just perfectly enough so that the curves would overlap. Can we trust observational data? Those of you who know me, I don't. Not when you're trying to compare treatments within a cohort where there's been a long historic precedence of careful selection of patients. Radiation really has only been delivered to what I call kind of surgical rejects, the patients that the surgeon doesn't want to operate on. We haven't been at the table to talk about the operable patients in the past. This is something that's only new, and these data are from the past. What data we can trust from observational database is what people are actually doing. And there are some data that conflict with this, but here, a large SEER data set, 30,000 plus patients, shows a 15% decline in the use of surgery for stage 1A non-small cell lung cancer, coincident with a rise in radiation in the era of no level 1 evidence to let us know if this is the right thing to do. And we'll talk about that some more. And I appreciate Dr. Karras coming here to give some additional perspectives on what happens when these patients fail. And this is not coming because of the 10% who never get any treatment. There's a third bar at the bottom. That doesn't change. This is shifting preferences. And let me talk a little bit more about all these retrospective data. I think they all belong in a graduate school for students to do homework assignments and get grades. I don't know why they're being published in the literature. On the left, you have data that gives us reason to celebrate. Oh my God, look at this. And then the pooled analysis came out. We don't need to even talk to our surgeons anymore. And look on the right. Different database, large difference, and this is reason for confetti at their meetings. If you look a little deeper, who's publishing these papers? On the left, at least there was one thoracic surgeon involved with the MD Anderson group. On the right, none of us were at the table. Maybe if we were, those curves would be a little bit closer. At the end of the day, what do? As Brian said, 3 of us up here were on the guideline committee for lung SBRT. Greg Videtic led the charge and presented the summary at ASTRO. This is him. This is from my camera. And one of your SACME questions is, where did we set the bar? We asserted, I don't know what evidence we really used, is that, look, if the patient has a greater than 1.5% risk of mortality, it's okay. You really should at least talk to them about SBRT. But if it's below that, it is absolutely fine just to go ahead and take them to the operating room. The outcomes of surgical patients these days are remarkable. We'll talk a little bit more about that later as far as what perceptions we may have and how they may be wrong. And where did 1.5 come from? Well, it's kind of a number that thoracic surgeons often talk about. Oh, the mortality is only 1.4%, 1.5%. Seems to be an acceptable metric. So we use that language with 2 thoracic surgeons on the evidence-based committee, because we thought it was most palpable. Don't worry, it's already been attacked. Where do you come up with that number? So you'd think that, my goal is to push SBRT to the finish line and win and quarterback it to victory. It's not. I am a clinician scientist. I am very interested in never being involved in giving inferior to a treatment unknowingly, and I would like to see some level 1 evidence. I am a connoisseur of phase 3 trials, and I feel like we need to keep pushing hard to make these things happen. Look at the advances in thoracic surgery that we may not be aware of. VATS came around same time as SBRT, 1990s. And over time, lots of data has shown its advantages, including randomized data. It is better. Reduce operative time, blood loss, shorter hospital stay. I was at MD Anderson last week, and the thoracic surgeon told me 1/3 of their patients go home on post-op day 1. Tomer doesn't work at MD Anderson, and his patients go home at post-op day 1 as well. Less post-operative pain, similar survival outcomes, and the patients do have measurable differences in quality of life. But let's not get ahead of ourselves. It does not actually improve survival, just kind of the patient's experience, which is what I think is going to cause a problem when it comes to, in Valor, trying to measure quality of life differences. I think the patients who have VATS and are successful will not be filling out devastating outcomes on their survey reports. This is a problem for us. We talk about the difficulties of exporting high-quality thoracic surgery onto the field, and there is variability. There are some places that have higher mortality rates, 5%, at 90 days, 9%. I mean, when you say a 9% mortality rate, those patients all signed an informed consent form thinking they'd live longer if they had surgery, and meanwhile, they died within 3 months. You and I think, have talked to families over time. They don't like it, and it'd be nice to see a different option. However, we have a challenge with regards to exporting high-quality post-SBRT surveillance. I'm sure all of you in the audience who have delivered this treatment know this conundrum. Not all radiologists are astute and reading the literature, and it's our job to educate them. Some good work has been done by colleagues in North America and Europe to try to get assessment of how we should be scoring these things, and some simple guidelines to help our radiologists not overcall. They are constantly overcalling it, and in Valor, we just had to add a new definition to the RESIST criteria for post-SBRT evaluation. Instead of CR and PR, we have something called CD, cannot be determined because of scar tissue. Nonetheless, this is kind of the best evidence as it continues to evolve, which are what's called high-risk features, and there's several publications. And there's 7 of them that are widely accepted. I really like number 6. I always urge our multidisciplinary team to please show us the coronal and the sagittal pictures of the scar. Here's my patient, 18 times 3. As you can see, at 12 months, it looks like a supernova happened. And over 15 months, it collapses. And it collapses in this kind of like linear pattern on the coronal image because I deliver coplanar SBRT. However, if you have a cranial caudal bulge, you can't really blame your beam paths anymore for that. But it's only one of the many high-risk features. Now, I would also point out that as we continue learning, we're already crossing off some of these high-risk features, including the belief that, well, if it starts to grow and then get smaller in the first year, that's okay, but after 12 months, we need to be panicked. If we mismanage these and we take patients to the operating room and they die or have a major complication from the salvage surgery, the reason for that complication isn't surgery, it's a decision to do upfront SBRT. Here's a paper you should all become familiar with if you're involved in this care. It was just published last month. 88 patients without relapse. I think Dr. Slotman in the room was one of the people who was asked to score these things. And again, no one had relapse, but look what happens to the scans, things enlarge. How often did things enlarge? Almost everybody. Radiologists can panic if they're not educated, and they use the most dangerous words in radiology. Malignancy cannot be excluded. How many happened in the first year? 64%, 86% after the first year, and you can see sometimes, oh, let me just get more scans. If it grows again, then I'm concerned. 14% of the time, it did continue to grow. How often were these high-risk features? Well, one high-risk feature is okay, but 2 or 3 I get worried. How often did 2 or 3 happen? Look, half the time, 2 or more. Quarter of the time, 3 or more. Definitely reason for panic and doing something stupid. Recommendations that were made, look at this. Ordering more scans. Our surgeons love these data. They're now starting to dig through SEER to say that SBRT causes even more skin anxiety. PET scans being ordered and biopsies as well. I think it's good medicine to have been doing this, but it just shows, mismanagement could occur outside of the academic setting. Or places that have high-quality multidisciplinary teams. And so here's this guy, here's the same patient. This is a 5-year survivor, and you can see the tumor enlarges, or whatever, the scar enlarges, and then it shrinks, and then it enlarges again, and then finally it enlarges again. Now, fortunately, they had this steel to watch this thing enlarge 3 separate times and leave him alone, and finally it kind of like just dwindles down. This patient's inoperable and probably didn't have a surgical option. If we're messing around with operable patients, we could definitely hurt this patient. Now, little bit of hope as to would we actually hurt the patient. MD Anderson pooled their data and some other publications and found 37 who had undergone a salvage lobectomy after SBRT. Interestingly enough, a lot of these patients actually had been originally deemed inoperable, yet still could be operable. I would caution they were very highly selected. This paper doesn't include all the people who failed, who couldn't be operated on. But let's say the surgeon makes a good decision and says, I can do it safely. Well, can they? So here you are, 4 institutions, 37 patients, and half were men. And the median time to failure, wow, only a year and a half. Maybe it wasn't failure. No, it was. All these patients had biopsy-proven failure, and the path confirmed it. Prior SBRT, and some of these had gotten, SBRT for oligometastatic disease to the lung. Salvage surgery. VATS really couldn't be performed all that often. And this is a place that loves to do VATS. Extensive adhesions were reported in about half of the cases. So it is technically difficult, but they did it. They got it out with lobectomies, sublobars, and negative margins 100% of the time, and no one died from an SBRT-related complication. There was one death, but it wasn't because of SBRT. And this is the Kaplan-Meier curve after the salvage. So it seems like a good option, and it tells us, the Valorous trial probably will look just like the VA larynx trial, which, by the way, for survival had a p-value of 0.94. Dr. Karras. So, delusionally optimistic, or do we really have a reason to think we're going to be successful? To design this trial, we spent 2 years talking to all the PIs of the other studies to figure out what was going on, what happened, and there was a lot of conversation before this came to light. This recruitment model is naive. Even if the surgeon truly wants to has equipoise and wants to randomize the patients, how well can they describe radiation? It's been shown by Jenny Donovan's team, who successfully randomized 1,600 patients on the PROTECT trial, that the longer amount of time a physician spends talking about a treatment, the more likely that's the one that they want. So we have to get the surgeon, or whoever's doing the recruitment, to speak 50% about this and 50% about that. A surgeon can elegantly describe everything about surgery, from the pre-op visits, where to park, the name of the receptionist, the perioperative team, post-op, all these things. What do you think they have to say about SBRT? Do they even know how to select the patients? Central tumors for surgeons is different. They just look at the distance from the surface of the visceral pleura. They don't have the same definition as us. They might say, well, I don't know, they'll give you some tattoos and do a scan, and I'll talk to you about it there. So a clinical trials monitor, actually for one of the studies, was in a room and heard this, reported it back to the CEO of the company that was sponsoring it, and from there was ordered, shut the study down. It's never going to happen. Doesn't work. So what we have is a very collaborative spirit. The patient, we recognize that the patient goes down this journey of biopsies, PET scans, all sorts of PFTs and others. The man needs some cardiac clearance. And I think that the patient is subject to a circus of information and misinformation. People who are well-intended, but just don't know what they're talking about. People in the waiting room, the mailman, the neighbor, right? We've all heard this as physicians. People get advice from all sorts of wacky places. Forget the internet. So as they go through this, they've signed an informed consent that puts a navigator in their lap to basically talk with them and safeguard them from all the discussions as they go through. They sit with the surgeons to get the full comprehensive description. They sit with the radiation oncologist who can describe it's more than just a couple tattoos. And then afterwards, they come back and have a discussion and say, look, are you comfortable now to be randomized? And the beauty of the VA study program is that we have a 1.0 FTE whose only job it is to recruit patients to this study at each of our medical centers. So they can be there, they can call them at home, talk to them, move their appointments around, become their friend. And if you've ever worked in a VA, there's a special bond that occurs between the clinicians and the patients. And the magic dust is that, and this is barred from the PROTECT trial, is that the patients all have a preference, but the preferences are uninformed. I want this, I want that. Our job is to have the study coordinator with the physicians get them to the point of realizing we don't really know what the best treatment is. That is the truth. I welcome debating any surgeons about this, because at the end of the day, there is no level 1 evidence to confirm that surgery is better. And when the patient gets to the state of mind, which is, you don't really know what's better? Well, thank God there's a study. Sign me up. And that's been our experience, and we randomized 20 patients so far, already ahead of the ACRO and R2G studies. The other question that we have on your CME is, the stablemates you may have heard of. This is available outside of the VA. Some of you may be enrolling patients. They use a different randomization. Before the patient even comes in, they've been randomized. So now your challenge is, would you like to be in the study? And you can kind of bias and say, well, thank God you were randomized to surgery, or thank God you were randomized to SBRT. And they can either choose to go on the study or just go off study and be followed. It's a pre-randomization. And that's the study question. That's your question. So that's all nice. I don't know if I advocated for SBRT or not, but Dr. Karras is going to talk to us about this. He can also talk about the Stars-Rosell pooled analysis, where SBRT actually won by, 16 percentage points? And I'm curious what Dr. Karras thinks about SBRT.
So what do I think? Well, I think if you asked me what I thought when that photo was taken, I would have said SBRT obviously stands for surgery is better than radiotherapy. Drew's already made a lot of my arguments for me. It's real nice debating someone who you agree with. The truth is we don't know. So my thoughts on SBRT don't necessarily represent those of the entire surgical community, so that's one disclosure. I've been thinking about this issue for a long time. I've been working with Drew for years, and we've been planning and now executing Valor for a long time. And I really, I'll tell you what I think, but I'll also tell you I'll try to tell you what I think other surgeons probably think, and things I've heard other surgeons say. So you have an idea of probably what a more, a less neutral surgeon thinks, and the people that you're probably really going to be dealing with. And I'll also tell you what I lose sleep over, which may surprise you. It's not really about losing patients from my practice to your practice at all. So just to clarify for you, I was at the Miami VA for 11 years, and I'm still on staff there, but only to do this research project. I'm actually now in private practice in Orlando, so I've seen both sides of the coin now. So first surprise, I think SBRT is a good treatment for early stage lung cancer, maybe even as good as anatomic resection, but I'm not sure. I think most surgeons would grudgingly admit that the SBRT results are better than we would have thought. Ultimately, I hope that our study, Valor, gives us real data that can direct us to which patients do better with surgery and which patients do better with radiotherapy. It may be related to anatomy, to tumor size, location, tumor biology, or something we haven't even thought of yet. But I don't think all operable patients will be best served by one modality. And what do I mean by better? Is it 5-year survival, or is it treatment experience? That's important too. Certainly quality of life altering complications will factor in. But for patients to continue to choose anatomic resection, the surgery outcomes will have to be a lot better than the SBRT outcomes. If the results are close, many patients will want SBRT even if they have to accept a slightly lower overall survival rate. These will be deeply personal decisions, and the decisions will belong to the patients and not to us as their clinicians. We first need the data to share with them, though, and by data, I mean good data. Drew's already discussed some of the issues with the SBRT data, but let me give you a surgeon's point of view. If you come to us with studies that showed success of treating suspicious but undiagnosed lung nodules, we'll laugh at you. The statistics of how many of those lesions should have been cancer are meaningless to surgeons. There are no surgical studies, at least none that I can think of, that tout the success of treating a disease that patients in the study may or may not have even had. The common sentiment I hear from surgeons when they review the SBRT literature is that SBRT works really well in patients with benign disease. That's not what you want. So you can't just rely on the statistics to explain that away. It's an emotional argument, to be sure, but it's an emotional issue for us. This is what we live with. So surgeons won't give up an operation that has been treating lung cancer for decades based on SBRT curing maybe cancer. You also lose some credibility when you quote the Stars-Rosell pooled analysis. I've had my own radiation oncology colleagues tell me that SBRT is at least non-inferior to surgery based on that analysis. Those trials accrued less than 4% of their targets before closing. So think about that. 22 patients of the required 960 for Roselle and 36 patients of the required 1,030 for STARS. That wasn't even in the principal paper. The few patients who had surgery had disastrous outcomes, well outside of what would be expected for any surgeon, let alone surgeons selected to participate in important trials. The combined operative mortality was 6 out of 27, which is 22%. These were operable patients. The mortality rate should be around 1 to 3% and probably closer to 1%. So there's a little event happening this weekend in Minneapolis. Maybe you've heard of it, the Super Bowl. There are two teams playing, the New England Patriots and the Philadelphia Eagles.
Go Eagles.
Sorry, Brian. So let's do a little thought experiment. I apologize to those of you who may not be big football fans, but I think you'll understand where this comes from. So let's say the first play of the game results in a safety against New England. As unlikely as that is, it's actually happened to them in Super Bowl 46 in 2012, right around the time Drew and I first met. So let's say the Eagles return the next kickoff for a touchdown, and then Brady throws an interception that results in another Eagles touchdown. It's a pretty unlikely scenario, granted. But now it's 2.5 minutes into a 60-minute game. Roughly 4% of the allotted time has elapsed. The score is 16-0 for the Eagles. Now, how many of you would be willing to bet your next patient's life on the Eagles winning the Super Bowl? So think about why you're hesitating and laughing. Is there anyone here from Atlanta or Jacksonville? So the Patriots are traditionally a strong team. While the players change and the situations change, the coach, the quarterback, and their principles of being fully prepared and having every player focus on doing their job are constant. If you believe they cheat, well, then they have that going for them too. Whatever it is, they have a winning formula and they tend to finish strong. Disasters happen, but they overcome them with surprising regularity. They adjust and they win. 2.5 minutes is just too early to make that call. It's the same thing with surgery in this paper. Surgery is traditionally a good treatment for this disease. Disasters happen, but statistically the patients do well. The studies closed really early. The surgical results are uncharacteristically abysmal, but the studies closed long before they achieved the required power to draw conclusions. So drawing any conclusions from this really only weakens your credibility. So you need better data, and hopefully it's on its way. But in the meantime, you have to understand that what your data actually shows. It shows SBRT is a promising treatment, but like I tell my patients, in 2018, the standard of care is still surgery. That may change one day, but if it does, it will be based on solid data and not leaps of faith. Surgeons will accept a change based on real data. How many vagotomies and antrectomies have been done in the era since H. pylori and proton pump inhibitors arrived? Operations go away when better treatments are available, but my prediction is that it won't be quite that dramatic for SBRT. We probably will have a population of patients that will do as well or better with SBRT and another population that we think do better with surgery. So surgeons also have concerns beyond the limited survival data that we have now. Part of what we do in the operating room is staging. A significant percentage of patients have occult N1 or N2 disease, about 10 to 15%. We surgeons find those patients if we're doing our job properly, and we get them adjuvant therapy. Actually, you give them adjuvant therapy. The combination of adjuvant chemotherapy and radiotherapy improves their survival. Not by a lot, granted, but by enough to make us offer it to most patients and for most patients to want it. So SBRT does not identify those patients. There may be some immunomodulation with radiotherapy that convenes some other benefit, but make no mistake, SBRT results in missed opportunities for treating occult advanced disease early. In the high-risk, inoperable population, that probably doesn't make too much difference. But in the operable population, these are patients who will tolerate adjuvant therapy, and we surgeons are concerned about the pathologic staging to identify which patients can benefit. We'll need to see cancer recurrence rates, particularly in lymph nodes, and overall survival in this particular population to really understand the implications of not identifying and treating occult nodal disease early. Is there a survival advantage to treating microscopic nodal disease early as opposed to much later when the disease becomes apparent on surveillance imaging? We don't really know. I personally would rather treat it while it's microscopic until we have data that shows it doesn't matter. So what about local recurrence? As Drew pointed out, we're making headway in trying to differentiate local recurrence from scar after stereotactic radiation, which is great, but it's far from perfect. And when recurrence does happen, how do we treat it? In inoperable patients, maybe we can offer them radiofrequency ablation. In patients who are operable, should they get salvage surgery? What do you think surgeons are going to think of that idea? Sure, there's a paper out of MD Anderson that Drew mentioned that suggests salvage resection is safe, but it's a really small series, and those patients were highly selected. And the selection criteria were not made clear in the paper. We have no idea how many patients were turned down and for what reasons. Even those patients experience significant morbidity, much more than we would expect for primary lobectomies. So I don't think getting to do a salvage operation for failed SBRT will be any surgeon's idea of a consolation prize, particularly when the patient could have had a straightforward operation in the first place. So speaking of straightforward, working with Drew over the past few years has made me realize that there are some misconceptions about how invasive thoracic surgery really is. Some of you may think that most patients suffer through long hospital stays and months of discomfort. The truth is that about half of lung cancer operations are now done with limited access or so-called minimally invasive approaches. Patients are often home within a day or two of their operations. Not all of my patients are home on the first day, Drew. But we do have those patients that are home in a few days, and most of them, after a few weeks, do not have any residual pain or any residual shortness of breath. So this isn't true everywhere or for every patient, but long hospital stays with huge thoracotomies and debilitating pain are no longer the state of the art. If the last time you saw lobectomy was in med school or never, I encourage you to ask your local thoracic surgeon colleague if you can come observe a case and follow a patient's hospital course. You may be impressed, or not. I just operated on a guy who survived cobalt therapy years ago. That was awful. Have you made some progress since then? It's important to have an understanding of the alternative treatments for a given disease, particularly as they evolve over generations. So certainly as the incisions get smaller and rib spreading is avoided, our operability criteria have relaxed. While we minimize the impact of the incision on the chest wall and on the associated impairment in respiratory mechanics, we found that we can actually operate successfully on patients with much lower measured pulmonary reserve. So the old cutoffs are going away, and we're operating on patients with much lower FEV1s and DLCOs now. So it's not only about how much lung we're removing, it's a lot to do with how much chest wall impact we're having. So we surgeons are concerned about survival with SBRT compared to surgery, with early treatment of occult metastatic nodal disease, and with local recurrence and the need to do potentially risky salvage surgery instead of more straightforward primary operations. And you should be concerned about these issues as well. It may be that there's no cause for concern, but again, you need the data to convince us. But none of these concerns are what causes me to lose sleep. I'm actually pretty happy about my equipoise for valor, and I'm proud to be participating in a trial that hopefully sheds light on some or all of these issues. Even if it turns out that SBRT is not quite as good as surgery, and some or all of the concerns I've mentioned turn out to be serious, I know we're being extraordinarily careful. We're watching our patients, we're watching our surgeons and our radiation oncologists very closely. We're making sure all the SBRT is state-of-the-art and all of the surgery is state-of-the-art. We're following the patients closely. We're requiring biopsies for suspicious nodes pre-treatment. Our surveillance after treatment is rigorous. All decisions are made in a true multidisciplinary fashion. If treatment failures arise, our local multidisciplinary groups will catch them early and will formulate a salvage plan. But these checks and balances won't be duplicated in normal practice after the study closes. So let's imagine that SBRT turns out to be equivalent to anatomic resection in terms of survival. Let's also imagine that nodal recurrence is higher in SBRT, as we suspect, but as long as it's treated when it's discovered, the patients end up doing fine. This will mean that SBRT requires rigorous follow-up imaging. If that follow-up doesn't happen, then the treatment is not as good. SBRT is not likely to become a fire and forget therapy. It's going to be a treat and follow very closely modality. Without that follow-up, surgery will definitely be a better treatment because it will define nodal involvement immediately and adjuvant treatment will be delivered immediately. Without rigorous follow-up, the progressing occult disease will be missed and will go untreated. So I'm concerned that the real-world outcomes will not be as good as what we find in our controlled trial. And I lose sleep over whether I'm going to help provide proof that you have a good treatment modality in SPRT plus surveillance that some of you change by becoming lax on the important surveillance component. Or maybe you'll ignore a mildly hypermetabolic node on PET that should have been biopsied and upstage the patient. Sure, in this room, you'll all shake your heads no and say you'll follow the guidelines. But that's the reason you're in this room, is because you care about them. It's not true for all of your guidelines now among all of your colleagues. All of us follow guidelines based on convenience to some extent because they're guidelines, they're not laws. At my own tumor board, now in private practice, patients have been presented by my radiation oncology colleagues as non-operative candidates or as not wanting surgery in order to get a consensus opinion from the tumor board to recommend SBRT. This is not what the ACRO guidelines require. I know because I helped write them. Are radiation oncologists qualified to determine operability? Are you qualified to have a discussion with a nervous patient about surgery? Almost no patient shows up in a surgeon's office wanting surgery, unless it's cosmetic surgery. They're often afraid and their fears are often unfounded. A common concern is that cancer spreads when it's exposed to air. We hear that all the time. It's our job as surgeons to explain to them why surgery is indicated and to put their minds at ease, and we're really good at it. We enter a sacred and time-honored covenant with them that we will see them through the operation and recovery, and we'll be there along every step of the way. As radiation oncologists, you can't hope to assess operability and comfort prospective patients' fears any more than I can have a proper discussion with patients on radiotherapy. Beyond, you'll get a tattoo and some energy. So the guidelines are important. They protect patients and they protect us. They're important in the current era of treating inoperable patients and patients who refuse surgery. They require a real surgical evaluation. The guidelines require real surgical evaluation. But the guidelines will be critical for success if and when SBRT becomes broadly applicable to operable patients. Those guidelines will impact survival. So please, for today, give your surgeons an opportunity to confirm inoperability and to discuss patients' concerns. In all likelihood, you'll pick out the inoperable patients as well as they do, but maybe you'll be surprised by one or two. And when the data is in and the new guidelines are made based on VALOR and other studies, read them carefully, understand why they're important, don't fall into the traps like trusting the Stars and Roselle pooled analysis. Don't just deliver radiation, treat the patient and their disease. If surveillance is important, be a part of that surveillance. You don't have to look at the scans yourself, but you have to make sure, as we do as surgeons, that the surveillance is happening, that your colleagues, either the pulmonologists or the oncologists or yourselves, a lot of surgeons follow our own patients. But this, the surveillance, make sure that that happens. So we'll need to understand the data, how the results were achieved, the significance of the findings, and we'll need to present all this information to the patients and their families so they understand the advantages and disadvantages of each modality and so that they can make good personal decisions. What we're doing is we're adding a modality. There'll be gray zone between which modality is better there'll be patients who I think will be obviously better treated by surgery and other patients will obviously be better treated by stereotactic radiation, and there'll be a gray zone. And I think what we'll see is that one modality may not be as good as the other in terms of 5-year survival, but that might be acceptable to a certain group of patients who are trying to avoid a certain treatment. We see patients right now who don't want any kind of radiation because they know of a family member who had cobalt. It's not a rational choice, but they come in not wanting radiation. They may want surgery even if the surgical mortality is a little higher. I suspect it'll be the other way, that what we'll find is that the stereotactic radiation outcomes may not be quite as good as the surgical outcomes at 5 years based on some of these issues. Some of it may also be stress over what their scar is doing and whether they have a recurrence. But patients may accept that in order to not have an operation that has its own mortality. risk. So this will all be about the patients having good information and making good decisions for themselves. So I want to close by saying that I owe a great debt to Brian Lally for introducing me to Drew, and to Drew Magnacki for inviting me to participate in Valor, and I appreciate the opportunity to share one surgeon's thoughts with you today. Thanks.
Thanks. Last year, everyone had cool titles like Profound, Radical, and all that other stuff, so I decided this year just to call it Extreme SBRT. That's my disclosures. Wanted to do a little sidetrack since we're talking Super Bowl. Since the Eagles are going to be taking on the cheating Patriots, the line is like 4.5. The opinion of the panel is that the Eagles are going to win, except for Dr. Finkelstein. He thinks it's the Patriots. I asked him why, and he said because Tom Brady was cute. My prediction is 24-17, the Eagles. And whenever you see the Eagles logo, it may be related to a question to pay attention to, because I'm not allowed to use the Uncle Sam thing like last year. So I was part of this white paper, and to kind of figure out why to give some guidelines for use of SBRT when there may not be a lot of literature in certain situations. And so what we did was we tried to focus on like 4 different areas. We developed 4 different teams, and I was going to focus mainly on the middle 2 today. Some challenging medically inoperable, and how to handle high-risk situations. This is the classic patient that comes into the clinic. He's got oxygen. He's on wheels. And Bob Timmerman kind of pioneered some of the early SBRT data at Indiana University. And it was interesting because in the sick population, you got very good local control and pretty good survival. But what's interesting is I learned from this paper, the best way to get a paper in the JCO is has excessive toxicity as your first 2 words in the title. And I got tired of seeing it after a while, but he did find out that, the central lesions had a little bit more toxicity, and it's developed this no-fly zone picture that you see everywhere out there in the literature. I also thought it was interesting that when you looked at some other things that have come from there, we now have studies where the primary endpoint is not survival, it's not local control, but it's looking at something like toxicity with grade 3 or above at 1 year. So the RTOG did this study where they randomized a single fraction to 34 gray versus 48 gray in 4 fractions. And what they found was that the 34 in a single fraction had less toxicity. And so that's what they're kind of used to move forward in their next study. But coming back to the question is like, how do you treat this? And I found this interesting because this was in the Red Journal last year, and I still don't know what the discussion was because I don't follow Twitter like some people. But if you see this, how would you treat it? And, none of those things that they listed there as options were something that I would use in my clinic for the most of the time. It's not the hammer that I want. But the RTOG tried to investigate how to treat central tumors, and they did a phase 1/2 seamless study, dose escalation, and they started at 10 gray and 5 fractions and moved up. And what they found was that they were able to do it in many patients with very low toxicity. So when we were trying to write the recommendations for treating centrally located tumors, we were considering data like this that was out there. We were also considering this data from the Netherlands. I think Dr. Slotman is in the audience today, where they didn't do, they did 60 gray and 8 fractions, and they similarly reported very little toxicity with very good local control. Some people still not may be comfortable with that. There's also data out there from Canada looking at, these were peripheral, not central lesions, but looking at 60 gray and 15 fractions, kind of slowing down the fractionation, so to speak. When you look at the way the guidelines were written or the way they drafted them, to treat central tumors, the definite no is not to use the free fraction course. Most people are using 4 to 5, but to me, this is a comfort level question. It's where do you feel comfortable in your practice and how to treat it. And I acknowledge not all central tumors are the same. They may be near different organs at risk. But some people, if you're using a longer course, I think that's perfectly acceptable. And you're going to find your comfort zone and probably use that hammer more regularly in your clinic. We also tried to discuss how to treat tumors that were greater than 5 centimeters in size. they're concerned that these have a higher risk for nodal metastasis, higher risk for disseminated disease, and most of these patients were not eligible for treatment on the SBRT, RT, or G-type studies. There are 2 papers out there, that you see listed here. They were very similar papers, both about 40 to 41 patients. All tumors were greater than 5 centimeters in size, and all patients had 50 gray and 5 fractions. The local control was about 90% in both papers. Very similar papers done. But I thought the more interesting paper when they were discussing this and look at and how to treat large tumors greater than 5 centimeters was this one from Canada. Not so much that the local control or things like that, but that they found that tumor size, is that me? Am I late? I'm okay? All right, I'll keep going, sorry. Oh, I got more on him. You ain't seen nothing yet. Anyways, tumor size correlated with other factors like local regional occurrence, disease-free survival, overall survival, and so forth. So there may be an argument in some settings, like large tumors, to be considering chemotherapy. But as long as you're able to meet your constraints, there's probably no reason to cut your limit at 5 centimeters as a tumor size when using SBRT. I'm an Eagles fan, but I did find this one a little weird, especially Bo Allen wearing the poodle head. So, another question we tried to address is, what do you gain or lose by doing a biopsy? Okay? I struggled with this one because one of the things they were kind of emphasizing when they presented this was that, well, if you don't get a biopsy, you may not be able to go on study. Okay? And I'm not too sure I agree with that one. There are some benefits. You get the ability to make sure that it's not a benign lesion if you're in areas where some things may be epidemic. It helps you differentiate between small and non-small cell carcinoma. There is data out there that was done in, I forget which one this was, either Lancet or New England Journal, I can't remember, but they did a randomized study to figure out what was the benefit to PET, and they found that they were wrong only 2 out of 60 patients. So very low rate if you're using appropriate criteria to select your patients that it may not be cancer. There's also data out here, as my colleagues were kind of just saying they like the biopsies, but there's data out there that says when you treat the patients, you really don't see any difference in the local control, the survival, or anything. The p-value is like as close to 1 as you can get. But I think when we considered this, or when they were putting this together, you really got to try to see if there's an opportunity to get tissue. But if the only way to get tissue is autopsy, you probably don't want to go that far. It's okay to treat or buy some time and re-image in a couple months and see if it's still there. So there was a pretty extensive section on synchronous or metastasis tumors, and I'm trying to get through this as quick as I can because I'm apologizing with the time. It was interesting the way this discussion went. When you're treating synchronous tumors, they don't do as well as solitary nodules or solitary tumors. They tend to do a little bit worse. But the metastasis ones tend to do as well as if they were a de novo or primary tumor. So, but if you can meet your constraints and do everything else, the recommendation was still to treat them. The only area where they got a little bit cautious was metachronous tumors in patients who had a pulmonectomy, because there was some data from, I think, the Cleveland Clinic where there was an increased risk of some toxicity. That was the only thing that really came out in that subject matter. Oh, Tom Brady, this is your friend? Yeah, every time I think of him, there's one thing I think of.
Number 12.
No, a TE fistula. Every time I see him, I think of TE fistulas.
Turn on this microphone. This football, it's a little deflated here.
It's all good. It's all good. Anyways, so toxicity, this was like the third question they get concerned about in there. And they, they mentioned some things, and some of the discussion was like trying to use different technology like IMRT and so forth to kind of get away from the organs at risk, but some of them may be contained within your PTV. But the way they wrote the guidelines, I thought was kind of interesting. Because the thing that you look at is that they're very careful if it's the proximal bronchial tree, if it's the esophagus, it's the heart or pericardium, to saying meet constraints, adhere to constraints. And in 2 of them, they were saying like 5 fractions or 4 to 5 and not the 3. But where it was interesting is that for rib and chest wall, there was not much of that, give and take, And the reason was because, when I see these types of tumors in my clinic, I kind of look at some of the Cleveland Clinic data, as they kind of switched over time, going from like 3 fraction to 5, and they found similar local control, but they found less chest wall injury. So I kind of believe that data. And so, I still believe that when you're treating these patients, the worst complication you can have is a local recurrence, and I'm not denying that. There's no role for chemotherapy in these patients, okay? But at my current institution, our preference is to kind of do 50 gray in 4 or 5 fractions. The reason the language was just a little bit different is they didn't want to run into the issue in case some patients would want to go on a clinical study and have them excluded or be contradicting to the idea of what would be in a clinical study. So, doing 54 gray and 3 fractions is acceptable, but I do admit when I'm practicing, I may do something different. Does that make sense what I'm saying? The answer is 54 and 3. And I found that on a test question for my recertification, and I was kind of shocked that it was like there, it was written like that. So that's why I threw it in there. What was that? Okay. I think that's it. I want to make sure I give enough time to Dr. Finkelstein, so I appreciate everyone's patience. And I wanted to thank the other members of the panel, as well as Dr. Fagenberg, who helped me prepare the slides for today. With that, I'll turn it over to Steve.
So you can put out in Selma's slides. So I feel a little bit like Nick Foles in that. So I'm going to come in sort of from reserve as a veteran to give a slide deck I've only seen 5 minutes ago, and I've never done that before. But can you put up Dr. Jabour's slides? Well, he does that. But my background is that this is the kind of stuff that made me a radiation oncologist. For those who know me, I was a surgical oncologist at the National Cancer Institute who was in the thoracic section, who wrote the chapter for immunotherapy in the Shields textbook, which is like our Bible for radiation oncology for thoracic surgeons. And so, am I going to do this without slides completely? This boy, with 4 minutes left. Okay, good. But what I did and Brian did is we recruited Salma, who's a rock star, to try to give you a short overview of where we stand today in 2018 with immunotherapy and lung cancer. I'm as passionate about immunotherapy as Drew and my friends on the stage are about certain aspects of lung cancer radiation. And if you guys remember, on the podium back now 3 years ago at ACRO, I was fortunate to be discussing at the scientific session, at the plenary session, to say that we need, as radiation oncologists, to be in the game where it pertains to immunotherapy. Okay, we got slides. Great. I don't need to tell you that lung cancer is bad. I don't need to tell you that we need to develop new and exciting therapies when we get to the point where we have advanced disease for lung cancer. Now, the platinum-based doublet is the standard of care for metastatic non-small cell lung cancer, except if you have an EGFR mutation or an ALK or ROS translocation rearrangement. In that case, the predominant therapy is still targeted therapies. With first-line chemotherapies expected with response rates between 15 and 30%, with second lines of about 25%. Now, while I was at NCI down the hall, Suzanne Topalian was working on new and exciting immunotherapies. Now, if you remember the history, immunotherapy's been around since Cooley toxins, like 6 to 7 to 8 decades, right? But we really had, and were confined to things that were immune stimulators like IL-2 gamma chain cytokines or interferon gamma. Then we had some vaccine approaches that did not work quite well, and that's what we had. And Suzanne, when she took her lab to Hopkins, started working on something called checkpoint inhibitors. Now, when I asked the question 5 years ago, how many of you knew about checkpoint inhibitors, you'd be like, what? But today, how many of you, raise your hand, how many of you know about checkpoint inhibitors? Like everybody. So where do we stand with respect to this? Well, Suzanne found that PD-1 is a key immune checkpoint receptor, which is expressed by activated T cells. It functions in peripheral tissues where T cell may encounter the immunosuppressive PD-1 ligands, which is PD-L1 or PD-L2. And those are expressed by tumor cells, stroma cells, or both. And the inhibition of the interaction between PD-1 and PD-L1 can enhance immune, i.e. T cell responses, and mediate anti-tumor activity. Now, in Suzanne's seminal work, anti-tumor activity was observed at all doses tested. There were 28% response in melanoma and 27% in renal cell, two diseases which are felt to be immunogenic. But when you look at, for objective response, it was 36% of patients with PD-1 positive tumors had an objective response. This was groundbreaking. We had a concept of altered self. What is altered self? Well, cancer's you. You should never go after you if you're the immune system, right? So we talk about the idea of cancers with a increased mutational load, meaning it could be more different than you, and maybe those cancers, we go after it more. Well, when you look at this on the slide on the left that Salma's put up, she shows that lung cancer is one of those cancers in which there is more mutational load. Imagine a situation when you radiate something. Do you think you make some weird stuff after you radiate it that the body can go after? And that, for me, as a surgeon, was the reason I became a radiation oncologist. When you cut it out, it's in a bucket. If it's sitting there for like, I don't know, a couple weeks to years to whatever, imagine what the body tries to do. When we talk about the scar, what is actually happening in that in vivo milieu? And interestingly, in the Dervo experience, so when you look at what of the, you're able to give this agent for a long time, and non-small cell lung cancer was one of those favorable sites that seemed to do quite well. So where do we stand today? I want you to walk out today knowing the SAM question. Nobody laughed at that joke. I want you to know the SAM question, but I also want you to know where we stand today with immunotherapy in the setting of non-small. So for first, as you imagine with clinical trials, we always put the novel therapy after what we have. And so these trials were done in the metastatic setting. First line is Pembro if PD-L1 is found in greater than 50% of the tumor, or Pembro with Carbo and Alimta, regardless of the PD-1 expression. Now, for second-line therapy, that's after progression on platinum doublet chemotherapy, you can give Nivo with any PD-L1 status. You can give Pembro if it's found in greater than 1%, greater than or equal to 1% of the tumor, or Atezo with any PD-L1 status. Okay, so remember, this is metastatic setting. This is not the area where radiation oncologists typically play, right? We play a little bit earlier. So in that trial, Keynote 24, which was a trial comparing, again, in metastatic non-small cell, it was Pembro versus chemo if you had PD-L1 greater than 50%. And this showed an objective response rate of 45% compared to 27% Pembro versus chemo, with fewer grade 3 to 4 adverse reactions. And this generated tremendous, right? So now there's all of these different checkpoint inhibitors. So I don't want to say me too, because that's a separate movement, but maybe me also in drug development, in that there's a lot of different agents playing around the same compound to try to achieve similar outcomes, and maybe some market share. Again, immune checkpoint inhibitors have interesting effects, and I'm going to go fast because I got 2 minutes left. But this idea that the combination of radiation with immune checkpoints can be maybe synergistic. That data comes from a lot of people and a lot of institutions now being interested in it. But where do we really stand bringing this into our practices daily? Well, this is a slide, I didn't notice this until I saw the slide deck that she actually cited me, so I thank Selma for that. But this is a slide that basically goes one step beyond the idea that when we radiate something, it causes double-stranded DNA breaks. When we radiate stuff, it causes a multitude of effects, of which we can look at the basic science papers, upregulation of class 1, generation of oxygen-free, a lot of things that are the new exciting things on the science side. So I'll skip ahead to the idea that when we radiate stuff, cool stuff happens, which may be immunogenic. So immunogenic that we talk about the abscopal effect. And we've been talking about this forever. And the idea of the abscopal effect is we do something over here, maybe with radiation, and something over here with disease goes away. For me, this is stuff that's been in the literature forever. The idea that we weren't planning on doing something over here, but it happened. And so the idea that it can happen has probably crossed all of the people who sit in this audience once in their careers. But it doesn't happen reproducibly enough. Now, when you look at data from the Keynote-1 trial, which was one of the original trials, Percy Lee published their experience at UCLA looking at patients and said, hey, how did the patients who got radiation in the combination with immuno checkpoint inhibitors do? And they actually did better. Now, there's inherent bias in this where these patients healthier could actually get the radiation, but it implies the idea that maybe we have a place in this game. But I think for us, and the thing I want to leave you with, especially for the SAM question, is this idea of stage 3 non-small cell lung cancer. This is where we play. We give radiation with a cisplatin doublet as the go-to move. But what is immunotherapy actually doing? Well, this might look like a SAM question. The Pacific trial by my friend and mentor, Scotty Antonia at Moffitt, basically this put an immune checkpoint inhibitor in the consolidative, basically after we give chemo and XRT for stage 3 lung cancers. Patients who had Durvo in this setting after definitive therapy of chemo and XRT had a better outcome as looked on multiple time points. Let's go faster. With pneumonitis rates that appeared very low. So there was, let's go back. So we go back to the key SAM slide here, right? We see progression-free survival with Duro having an improvement than placebo. This was published in multiple forums, including ASCO and ASTRO. All right, let's keep going. Lastly, could there be side effects? Yes. Here you see some of the side effects that can happen with immune checkpoint inhibitors. But unfortunately, the last thing I'll leave you with today is when you actually look at the number of clinical trials that exist in the stage 3 setting with radiation and adding in immunotherapy, there's only one trial, and actually Selma's leading that. So most of the trials, if you look at it across the board, are we're going to give immunotherapy after space. So with that, I'm going to say that immunotherapy is extremely interesting, and we should play a role in its future.
Thanks, Steve.